Welcome to the Doctor Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions, and we will discuss it on our pod.
All right, let's do it.
Let's do it.
Okay. Welcome, Dr. Sadowski. How are you, sir?
I am great. I am well caffeinated, and I am excited to get another podcast going with you today, Josh.
Awesome. Yeah, let's do another podcast. So I had a few things that I wanted to chat about. First, I just got back from PI, which is this really cool train the trainer, evidence-based medicine training. It's officially for integrative folks and mostly chiropractors, but it could be for anybody. So I love that thing. So just got back from that. Wanted to talk about that. Also, like really neat conversations within chiropractic about vitalism versus evidence-based practice. And I'm like, oh, this sounds freaking familiar. I've had these debates like ad nauseum in naturopathic medicine. And so anyway, I thought that was interesting. We could chat about that. But then and we're coming up on 1,000 downloads, which maybe by the time listeners are hearing this will officially hit. So we have to talk about like, we're 6 months in, we've hit 1,000 downloads. Like, how awesome do we feel? Or, what's our next step here? But then you gave us a really cool research article from your favorite journal, which is extremely clinically relevant.
Well,
and
hold
we should
on,
probably
Josh.
talk about that.
Hold on one sec. First off, also, for those who don't know, our podcast was highlighted by the University of Toronto's evidence-based practice as the top podcast for their evidence-based practice tools.
Boom.
Above Cochrane, BMJ, and New England Journal of Medicine. So look
Take
at us,
that,
though.
Cochrane. Yeah.
Well, thank you for everyone, for all the listeners who tune in and listen in. I hope we're valuable to you guys. I hope you learn stuff. And for those who want more stuff, go to Dr. Journal Club website. We have so much more to offer there. The podcast is just a snippet. If you really want to get into the nitty gritty and the nerdy details, go to that website. We have a bunch of free stuff. We have great stuff for members. There's stuff there that we don't talk about on the podcast. It's for members only. And it's just a great resource to use. So check us out.
Yeah, it'll change your life pretty much is what it comes down to.
Exactly.
Okay, so speaking of changing your life, one is a 50-year-old aging male with low testosterone and history
Do you really
of
have
cardio.
low testosterone, Josh?
What's that?
Do you really have low testosterone?
I am not 50 plus. I'm curious about my testosterone levels, but okay. So in our hypothetical example, 50 plus, a history of cardiovascular disease or just high cardiovascular disease risk, I think, and then comes to the doctor because I've had a zillion of these patients when I was doing family practice, and says, "I need some tea, man. I need to get jacked. I need to be happy. I need to be healthy, all the things." And I had this whole spiel that I would always say, well, we don't have a lot of research. And now, granted, this was like 10 years ago. We don't have a lot of research, and there's signals that it may be a high cardiovascular risk. And you have a history of angina or whatever. Like, hell no, we're not doing that. And then this study comes out. So anyway, so what do you think? I mean, let's jump into the actual. We should jump into the actual study, but it's just you suggested this paper, and I was like, wow, this is like literally clinically relevant to so many men out there and their providers, their medical providers, because this literally I saw like 100 patients go through my mind when I was reading this.
Yeah, and I see this a lot clinically as well, and I think too when it comes to the low testosterone. Just for some background information, the NIH actually sponsored, I believe it was a series of studies, or maybe it was just one randomized controlled trial, looking at the efficacy of testosterone replacement therapy for for men, and that was known as the testosterone trials. And the data is out there, and to show what what did it benefit over placebo when it came to supplementing with testosterone. And so
For
the
what?
issue,
What was the outcome?
I mean, the outcome is like, libido,
Oh,
increased
okay.
muscle mass, hair growth, all
All
those
the
things,
testosterone things.
all the
Got it.
like the hypogonadal symptoms that we
Hmm.
associate with low testosterone, or why guys think they have low testosterone. We have people come in, oh, I have fatigue, so I must have low testosterone. It's like, well, hold on, like there's the differential for fatigue is really pretty
At
wide. We
least
got to
three
figure
dozen.
out,
Yeah.
yeah. So, and the issue with all of this testosterone supplementation is that the safety data was never really well established. And a lot of the data comes from small randomized controlled trials
Mm.
or high risk of bias observational studies, and a lot of conflicting data. And we had some meta-analyses that said that there's no increased risk, or that the risk really can't be determined. And so the FDA in 2015 actually requested that manufacturers conduct clinical trials to see if there's any associated cardiovascular disease risk with the use of testosterone replacement therapy. And so that's what we have now in the New England Journal of Medicine, the paper
Your
that we're about to
favorite
talk
journal.
about. It's very much my favorite journal. It really is. I like the layout of it. I love how they're just straight and to the point. There's no, fancy analyses that are done. It's very, very clinically relevant, easy to follow.
Yeah.
It's just a well done journal.
Well, there's one major flaw. They don't
What is that?
publish meta-analyses.
No, they don't. They don't publish meta analyses, but I mean, I'm okay with that because
Yeah, yeah, you would be. No, just kidding.
we
Yeah,
have
no,
Talking to the
always
MJ.
clinically relevant trials for sure, and like clinic changing
Hmm.
trials are always in the
Hmm.
New England Journal.
Yeah. And so this paper was called the testosterone replacement therapy for assessment, or well, what the trial was, the study sort of broadly was the testosterone replacement therapy for assessment of long term vascular events and efficacy response in hypogonadal men, and that was just shortened to Traverse. So this is the Traverse trial,
Hmm.
but the actual title of the paper is Cardiovascular Safety of Testosterone Replacement Therapy by Lincoff et al. In July 13, 2023 of the New England Journal of Medicine.
Oh wait, that was just a week ago. It just came out a
Uh-huh.
week
So
ago.
this
Oh
is
wow,
very much like new,
cutting
brand,
edge.
brand new. Yeah.
Yeah,
Hmm.
cool.
And so, like I was saying, the purpose of this of the study was to assess the safety. Okay, this is
Hmm.
a safety trial, not looking at is it better than placebo for prevention of some sort of vascular event. It's not looking to see if testosterone is better than placebo at improving hypogonadal symptoms. It is a safety
Right.
study. It is looking at adverse events.
Which you rarely see at the primary outcome being safety data. It's usually
Yeah,
like secondary or tertiary.
yeah, exactly. And so, to get into the methods of it all, it was a phase 4 randomized, double blind, placebo controlled, non inferiority, event driven trial. So, Josh, do you want to kind of give a little bit of background of to that sort of word vomit as to what all that means if we were to break it down for people who don't understand?
Yeah. So, all right, randomized trial, most people are probably familiar with. But if not, we've got a zillion videos on Dr. Journal Club. Um, Same with blinding. So, double blind. So, that's important, right? So, they had a sham cream, I think they used, or sham
Hmm.
gel for that. So, it's also very, very important. You'll talk more about methods, but they did a really good job, I think, with blinding and masking.
Yeah.
Probably the thing that most people are not familiar with is the non inferiority piece.
And the
And
phase 4.
the phase 4. So, okay, so phase 4 is generally post FDA approval for efficacy. So we already know testosterone works. It's already been FDA approved for, name your condition, hypogonadism, name your symptom that you're trying to treat. The question is safety. And that's what usually stage 4 is, where you're actually, or phase 4, we're actually looking at post-marketing. It's already out there, and now we're trying to find some safety data. And like you said, I mean, it's kind of nice because usually things are powered for your primary outcome, and we miss adverse events. So safety studies are usually underpowered to find rare events. And so you will often miss that safety signal, which is why the FDA often requires these phase 4s. And then the non-inferiority. So usually that's a red flag, but not in this case. So normally you want to say, okay, is my drug or herb or whatever better than placebo or better than the alternative? And that's a standard trial that we're all used to. With non-inferiority trial, it's designed to say my drug or supplement or whatever is not inferior to name your intervention. And so there are all sorts of red flags with that we could get into. However, and I'd love your thoughts on this, I think this is an appropriate methodology for this because they're comparing it to a placebo, and they simply want to say, is the safety of this any different than the safety on a placebo? In other words, getting nothing.
Yeah.
And so that's what they're not trying to prove, that it's safer or causes more side effects than placebo. They just want to make sure that it's not
worse than.
It's not worse than, exactly.
Yeah.
And that's a perfect design for non-inferiority.
Yeah, because there's no reason, no plausible reason that we should think a placebo gel should be causing a heart attack.
Right. That's right. Exactly.
Just to put, like, let's say Vaseline on your skin, you're not thinking, oh my God, I'm going to have a stroke. Right?
Generally, yeah.
Generally speaking.
Depends on the context, but yeah, generally speaking. Okay. So
and then also it was what's known as event driven. Mm-hmm. And so what that means, and Josh, of course, interrupt me if need be, but sometimes when it comes to trials, the issue can be that sometimes the events that happen when it comes to looking at risk reduction. So, like, let's say we gave someone a statin for high cholesterol, but if in that study there weren't enough heart attacks to actually happen, we may not be able to truly identify how much benefit or lack of benefit there is with that intervention, right? So let's say we gave 50,000 people randomized, and 25,000 got statin, 25,000 got placebo, but only one person got a heart attack, right? The event is so rare that we really can't make much of that information. But if 5,000 heart attacks occurred, okay, now we can kind of say, okay, are these statins truly, reducing the risk or increasing the risk of these events occurring? So with this study, they waited until a certain amount of events actually occurred before running their analyses to make sure that they captured enough events to truly say, okay, is this actually safe or not?
Yeah, I thought that was great. I mean, the whole point is to be powered properly to be able to see this stuff. And so, yeah, like you said, it's powered based on the events. And so you need to make sure you have enough before you just crunch the data and say, oh, there's no difference here because, we just didn't have enough events or whatever. But yeah, no, exactly right.
And it was sponsored and designed by AbbVie. So before everyone kind of freaks out, there were a number of stopgaps.
Lose your mind! Yeah.
No, do not automatically assume a study is bad or that you can't rely on it just because it's sponsored by industry. If that's a very low level approach to critiquing a study, and for those of you who really don't like the pharmaceutical industry, this is not only happening with the pharmaceutical industry. Your specialty labs, herbal and dietary supplement companies are doing the same thing. They are sponsoring trials as well because these studies are expensive. Someone needs to pay for them, and they can't always be publicly funded by the NIH, the National Institute of Health, or some sort of other government agency or nonprofit organization. These are very cost intensive, labor intensive, lots of logistics going on. And so they do oftentimes require financial input from industry. And so it was sponsored and designed by AbbVie, But they also had clinical oversight by the Cleveland Clinic Center for Clinical Research. And I've actually been noticing that they've been doing quite a number of uptick of publications have been going through the Cleveland Clinic when it comes to research. So that's something just to kind of keep our eyes out on. And then there was also an independent data and safety monitoring committee that reviewed the safety data, and all adjudicated events were blinded. And so, what adjudication means is we didn't just simply say, "Oh, did the person report that they had a heart attack?" They actually went in to look at medical records, or perhaps let's just say they spoke with the participant. They actually confirmed that the diagnosis or the event truly occurred, and all of that was blinded. So they probably were looking at hospital records or whatnot, but didn't know who the person was or what group they were in.
Right.
And then also there was input or support from LabCorp. So they probably helped out with being able to provide free data samples or not data samples, blood samples, or storing labs and whatnot. So we have a couple of independent people who helped with this study getting done.
Yeah.
Also, the statistical analysis was independently done by the Cleveland Clinic, and then the actual final decision to publish was done by the authors of the study with no restrictions for the right to publish. And I think that that's really important because it means that AbbVie basically said, "Hey, if the results aren't in our favor, you still are allowed to publish." If there were restrictions, then the red flag should go up, because then perhaps they're probably cherry picking what they want to be published and what they don't want to be seen, or it may have just been a study that never gets published. So I think that that's really important and really lowers that risk of bias of it being industry sponsored. So what do you think about that, Josh?
Yeah, I think you nailed it. I mean, I think a quick glance, it should be a red flag, like that. It should perk everyone's ears up. But you're right. A detailed look. We know industry funding is associated with biased results. Like we have that empiric data. That doesn't mean that every study is, but it does mean that it's at a higher risk of bias coming in. And so you just have to look closer. And I agree with you. I mean, I looked like the cleanest would be, which they did not do, which would be we wrote the check and we walked away. It's not quite
Mhm.
the same. They were involved in the protocol development. They were involved in like manuscript review. But like you said, they didn't have final say. They couldn't bury the story if it wasn't good. They couldn't lead to publication bias that way. But also, just like as I was going through the design, I was like looking for design choices that maybe would have favored the industry. But I thought it was a pretty solid design. And the argument with industry sponsor, and we've got a great series of videos on this on Dr. Journal Club. Cochrane actually had this big debate back in 2008, I think, like these competing editorials. Adam, have you ever read those? They're really neat, really interesting
Probably
stuff.
not.
Where essentially one side was I think Lisa Barrow was arguing like it's just always bad. It's always a high risk of bias. And then I think Jonathan Stern was arguing not necessarily. You have to have a nuanced approach. And it was very influential for me to read through those debates. But I think the main take home for me was that it's like just because the money comes somewhere, that doesn't magically mean that it's going to be a biased result. There needs to be a mechanism. And so when you see funding, you need to be more aware, but you need to have a plausible mechanism of how that could have been biased, whether it's a loose design or selection bias or what publication bias or what have you. I didn't see that here. I was pretty pleased with the design. I am comfortable with the results. I don't think it's a I don't really doubt it would be a bias study based on the way they set it up.
Right. Okay. So now let's look a little bit more into the clinical components of the methodology of the paper. So they included participants. They included male sex with already established cardiovascular disease. So they already had a history of a stroke. They already had a history of a
So
heart
people I
attack.
would never have given testosterone to in the past. So very clinically relevant that we're going to see what happens when you give it to them. Yeah.
Yeah, so already people who are already at high risk, right? These are, and I would agree, people who perhaps initially I'd be really hesitant to wanting to even engage in the conversation, or people who are at high risk for cardiovascular disease, and that was defined as having at least three, so not just like one risk factor, but having at least three of the following risk factors: hypertension, hyperlipidemia, so high cholesterol, diabetes, stage 3 CKD. They were active smokers. They had an elevated high sensitivity C reactive protein, older than the age of 65, um, or had a coronary artery calcium score above the 75th percentile for age and race. And then also, all the participants had to be between the ages of 45 to 80 with hypogonadal symptoms consisting of low libido, difficulty obtaining or maintaining erections, fatigue or low energy, low or depressed mood, loss of pubic hair, hot flashes, and two fasting testosterone levels under 300 when blood was collected between 5 a.m. and 11 a.m. And that is important because as the day progresses, our testosterone levels naturally decline. So sometimes I've gotten people who are like, oh, my testosterone level is low. It's like, well, yeah, you got it done at 4 p.m. I would expect that. Sometimes I get people who want testosterone replacement therapy, and you see that they got their labs done at 3 p.m. and their testosterone is like 800, and I'm like, that's you don't have. I'm sorry, unless you're already supplementing, you don't have low testosterone. But yeah, so I mean, if we're thinking about like the population risk that this trial is including, is a very high risk population. We have
Right.
in older aged population that either has already had some sort of cardiovascular event or are about to get one.
Yeah. Yeah. High risk. I mean, it's like very, very clinically relevant because these are the people you would never touch with testosterone. And now it's like, oh, now we're going to find out what the safety data says.
Yeah. And I think it's also important to highlight like who was not allowed to participate. So anyone who had congenital hypogonadism, anyone who had a total testosterone less than 100, anyone with a history of prostate cancer or prostate nodules, if they had an elevated PSA, if they had thrombophilia, or if they were entering the trial with uncontrolled heart failure. And I think that those are reasonable exclusionary criteria.
Yep.
Yeah. Okay. And so the participants were randomized 1-to-1, meaning one person went to testosterone group, one person went into the placebo group. And then they were stratified according to the presence or absence of established cardiovascular disease.
Good.
And those who received testosterone got topical application of a testosterone gel, and the placebo group got a matching non-testosterone gel. So it looked exactly like that gel, felt like it, smelled like it, probably was sticky like it, et cetera, et cetera. So the only thing was that it just didn't have the testosterone in it. And I think that this is also really important from a clinical standpoint, is to recognize that this study only looked at topical testosterone gel application.
Right.
So if you're someone who's using injections or those troches or some sort of oral formulation or some sort of other formulation, we can't necessarily say that all forms of testosterone are safe. We only have it for this testosterone preparation, this topical formulation.
Yeah, I think that's fair. Yeah.
And then the doses were adjusted based on the repeat testosterone level. So everyone got their baseline levels. They were placed on testosterone replacement therapy, or they got placebo. And then after they would repeat their testosterone levels. They would adjust the dose to get it within a particular range. And they kept the levels between 350 and 750, or at least that's what they were supposed to be between. So they're not gunning for like 800, 900, 1,000 plus levels in the testosterone. We're not trying to get everyone just booming with testosterone. It's really just, let's get them in a normal range
Normal range.
that's
Yeah.
supported by the American Urology Association. And they also wanted to just make sure that the hematocrit didn't exceed 54%. Testosterone will kind of make the viscosity of your blood a little bit thicker. And that's what the hematocrit is essentially measuring. And so they just want to make sure that your blood isn't getting too thick, that the hematocrit isn't getting too large, because they don't want to artificially increase that risk for a potential clot. There is some thought that if the hematocrit is too high, your risk of developing a clot would increase. So that's an appropriate clinical decision, stopgap from a methodology standpoint, that I think is appropriate. And so anyone who had their testosterone above 750 or a hematocrit above 54%, they would just adjust the dose. And if that still persisted, meaning if their testosterone was still elevated and their hematocrit was still above 54%, even after going down to the lowest possible dose of testosterone, they were actually discontinued from the trial. And then anyone who developed prostate cancer or developed any sort of suicidal ideation also had to discontinue receiving testosterone and were asked to leave the trial. And I think that that's totally reasonable.
Yeah, I agree. Just real quick, the thought process on the suicidality, was it just that testosterone makes you more impulsive, and that's
I don't
the
know. I don't
yeah.
know. I didn't look into that. I don't know. I guess it's because maybe that's what it is. Because I know with the testosterone trials, they did show that mood was improved with testosterone
Mm.
supplement,
Mm-hmm.
and so there may be a component of that. I don't know.
Interesting. Yeah,
Yeah.
I just did a huge paper on suicidality, and this was news to me. But essentially, it's like impulsivity is like a major driver. Like you baseline depression, but if you're impulsive, that's like a super high risk factor. So anyway,
Oh,
interesting.
interesting.
And then I love the cool way they adjusted the dosing, right? Because it's like you got to keep the blinding. So
Hmm.
essentially, it was like done in it by a different party, centrally adjusted algorithm. The docs had no clue, and then they had fake dose adjustments for the placebo group as well.
I saw that too, and I was like, "Wow, this was actually really well thought out and
Yeah,
well done."
right.
So even the placebo group,
Mm-hmm.
if they had now remember all the repeat testosterone levels were blinded. So the first one, people may have known that I have low T.
Right.
Well, you had to have low T to be in the trial.
Right.
But on the repeat, basically they kind of continue with this sort of theatrical placebo. If it was low or still low, well then they just kind of adjusted their placebo cream to get more placebo,
Mm-hmm.
which I thought was really interesting too.
Yeah, and the patients and the docs never got the next level, so just nobody
Correct.
knew anything, which was great. I really do think that they kept their blinding. I don't think it was unmasked, from what I can tell.
Yeah. And then they looked at a bunch of different safety outcomes. So there was a primary safety outcome, a secondary safety outcome, and then tertiary safety outcomes. But I think it's really important to highlight that this paper really focused in on the primary safety outcome. That's what the statistical analysis was mostly geared towards.
Right.
And so secondary and tertiary outcomes are really viewed more so as exploratory, and we can't really hang our hats on them. And that's what the power analysis was calculated towards. That's what the event driven trial was geared toward. It was really meant on this. And so the primary safety outcome was the first occurrence of any component of a major cardiovascular event defined as a composite, so combining all of these as one outcome of cardiovascular death, non-fatal heart attack, and non-fatal stroke. And then they also kind of sub-analyzed all of those. So because this goes back to sort of the rare events, you would have to have the trial go on for a very long time with lots and lots of people in order to get, let's say, one heart attack. And so if you needed 256 events, you're going to be doing this for a very long time. And so if we just say, okay, if we were to ask people, would you rank a heart attack and a stroke and death from cardiovascular disease as all relatively,
Equally sucky. Pretty
equally
close.
sucky? Yes. Yeah. Most people would say yes. I don't want a stroke. No, I don't want to have a heart attack. No, I don't want to die from sort of cardiovascular cause. Okay, so let's just kind of pool that all as one, and that'll be
Yeah.
our what we call a composite. Sometimes you have funky composites where it's like non-fatal MI and toe pain, right? If
Right.
someone had toe pain, they'd be like, okay, I don't really care about that, but I care more about the heart attack. So this is a composite that makes sense, right?
Yeah.
So we have a primary composite outcome. Then when it comes to our secondary safety outcomes, it was not only that primary outcome, but then we also added in coronary revascularization. So we just tack on, okay, you have to get, percutaneous intervention or a cabbage. So you actually have to go to the cath lab and get some sort of revascularization of the coronary arteries.
So sucky, but not quite as sucky as the primary outcome.
Depending on who you ask, yes. Yes. And then the tertiary safety outcome was basically all of that, plus hospitalization or urgent care visits for a heart failure exacerbation, revascularization of any sort of peripheral arterial disease. So no longer doing just a stent in the heart, but now let's say doing a stent in the calf. And then any sort of venothromboembolic events, so DVT, deep vein thrombosis, so a blood clot in the leg, pulmonary embolism, blood clot in the lungs, or any other sort of thromboembolic event. And I was actually kind of I thought it was interesting that that was a tertiary outcome. I would have liked that to have been a primary outcome. I get that from a composite standpoint, it's a lot better to have like a DVT than a non-fatal MI because DVTs happen all the time. They're a lot easier to manage than, let's say, a heart attack. Um, they're usually not as fatal as the what can happen from a heart attack or the comorbidity wise. So it probably wouldn't have fit the composite. But from a clinical perspective, that's usually the first thing that I'm kind of gearing towards. I don't want you to have some sort of a DVT if we were to give you testosterone therapy. What do you think about that, Josh?
Yeah, I agree. I mean, it depends on what you're after. The strictest methodologic approach is to just have the really sucky stuff. And that's
Hmm.
what they did for primary. That was appropriately their primary outcome. But you're right. There's other important clinical outcomes, and so they used that in their composite. But again, it was tertiary, which I think is really good. Again, when you hear composite, you immediately, it's like you prick your ears up for a red flag as well. Just like with funding, it's like, okay, what did they put in their composite? Are they juicing the results here? And with like toe pain, like you said, and you could argue like, oh, we're making all these statements about MI, but really it was just DVTs that were the issue. But again, because their primary outcome was like the hardcore suckiness, I'm not worried about that. But it is clinically relevant, and so it is included just as a tertiary outcome. I'm totally fine with that.
Awesome. Okay, so in order to get statistical significance, they need to have at least 256 primary composite endpoints. So there had to be at least 256 quote unquote sucky events. 256 people had to have either a heart attack or stroke or die from some sort of cardiovascular event in order to get 90% power to detect statistical significant after adjusting for pre-existing cardiovascular disease. However, one thing that we also need to view is that they did not plan for correcting for multiplicity when it comes to their statistical analyses. And that's why we need to kind of be cautious when looking at results for the secondary and tertiary outcomes. So, what is this multiplicity idea when it comes to data analysis? If we were to run a statistical analysis looking for statistical significance, right, a p-value less than 0.05 that everyone is looking for whatever reason, and if we were to do that test over and 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 over again, we're bound to find one. And so if we don't correct for the multiple testing, chances are you're probably going to find something that has statistical significance. But that was due to chance. That was just because you ran a statistical analysis so many times that you're probably going to find something, right? If you're a clinician who's ordering comprehensive metabolic panels every time you see a patient, you're bound to catch an electrolyte abnormality that probably has no clinical meaning or really any sort of relevance to why you're ordering that. If you're monitoring someone with, let's say poor kidney function, and now all of a sudden, I don't know, their bilirubin is elevated for whatever reason. You weren't looking for some sort of bilirubin issue. You were just monitoring, let's say, their creatinine clearance or their GFR. And now, because you've ordered their 15th CMP in 10 weeks for whatever reason, you've caught something. That was probably just due to chance. It's probably just statistical noise. It's something that can be ignored, right? And that's what the testing for multiplicity can do. And there's pros and cons of doing that because sometimes it can be too strict. But if you're testing for multiplicity, you're essentially adjusting that p-value. So this way, a 0.05 is no longer statistically significant. You need something that's a lot smaller. So a p-value of 0.05 can basically be translated as, the results that we found are statistically significant, and there's less than a 5% chance that what we found is just due to random chance. So if we do some sort of test for multiplicity, that 5% usually turns into something like, let's say, 0.0025. So there's less than 0.25% chance that this is just some sort of random error. But they didn't do that in this analysis.
Yeah, good. I think you nailed it. Again, less relevant because they didn't really see much, but yeah, no, excellent. Mm-hmm.
And then they also ran their analysis under the assumption that some sort of event would occur in the placebo group at a rate of 1.5% on a yearly basis. And that's probably coming from just sort of what we know in the general public as to like how frequently are cardiovascular events occurring from a year-to-year basis. And then they also assumed a loss to follow-up rate of 2% annually. And then they, from that, said, okay, we need a total of about 5,400 people to get 256 cardiovascular events in order to find some sort of statistically significant result. And then they also did a couple of sensitivity analyses to confirm their primary analysis, which I thought was interesting. One, they had what they considered to be a full analysis. So everyone who went randomization got analyzed. And then the second analysis was considered the safety analysis or their safety data. And that was only on those who were randomized that got at least one dose of testosterone replacement therapy or placebo. And I think that's totally fine. I don't think that that's viewed as like what we know is called per protocol analysis. Typically, those are more biased, but I think in this situation, it makes sense we want to see, okay, are the people who are actually getting testosterone replacement therapy having these events? And so that was really the main data set that we're looking at when it comes to this study.
Yeah, and I think the key there is because it's a safety study, right? So
Mhm.
we're really interested in not so much false results like we would be with an intention to treat, but actually like if you got testosterone, does it cause these issues or not? Yeah.
Mhm. And then what they also mentioned in this study was um, because at initially the event rate was so low, they actually had to limit the number of participants who were at risk for cardiovascular event, but didn't have established cardiovascular disease at baseline, to no more than 70% of the total participating population. So at least 1/3, basically, of the people in the study had to have some sort of history of a cardiovascular event, whether it was a non-fatal heart attack or a non-fatal stroke, in order to get an adequate number of events to occur from after being randomized. Because otherwise, this trial may have gone on for years and years and years, or they needed more people. So from a logistical standpoint, this was just like, hey, we need this trial to, we need to have enough events to go before to make this determination of safety. And I think that's totally reasonable.
Yeah, I agree. Yeah, no problem with that at all.
Okay. So now when we look at the actual data, when we're looking at the results, there are a total of 5,198 included in the safety analysis. And so that was just shy of the 5,400 people who were needed to obtain the events. However, 372 events actually occurred. So they were able to maintain their statistical power. They could say with basically 90% confidence that the results that we found are truly statistically significant. And then the treatment duration, so how long people got testosterone or placebo gel, was on average 22 months plus or minus 14. And interestingly, both had a discontinuation rate of about 60%, which is really rather quite high. And then the follow up time was just shy of 33 months in both groups. 21% withdrew prior to the end of the trial, and then an additional 18% on top of that did not go to their end of trial visit. So I think that this is something that we need to kind of take into context when we're looking at the results and kind of how we interpret them, because we have a relatively high discontinuation rate, much higher than what I would have suspected for people who typically want testosterone replacement therapy. And then also we have a rather high risk of bias coming in from people just from having a lack of data to analyze.
Yeah, that wasn't clear to me. They didn't do like the cohort flow diagram where you see exactly like how many people followed through. So like it seemed to me that they like the primary population was almost everybody, right? Like that safety population was close to 5,200 participants, and so it was unclear to me like the people that didn't show up, what are we missing? Like what was the actual missing data? Were the docs still going in and trying to adjudicate if they had an event or not? Like that would be important, and if that was missing, I agree that would be a risk of bias. But if they were actually like still analyzing those patients, but just didn't have their last blood draw, like that's less relevant to me. So that wasn't clear to me from reading the article. And the problem with intention to treat analysis is it's never clear. Like they did a survey and there's like 7 different ways of, when people say intention to treat analysis, it could be like one of 7 things. So it isn't clear to me. It needs to be better reported. But yeah, I don't know. Did you see any red flags about the specific missing data, or you think it's all right?
I also didn't have access to the supplementary files. I only had access to the main manuscript. But I mean, if we think about it too, right, we had 350 or 372 events.
Mm-hmm.
And so, and we're also having equal discontinuation rates and loss to follow up in both groups. So if there was any sort of like noise towards one way or the other, we would be able to catch that.
Yeah, so that's a really good point. So if there is missing data, the first thing you want to see is if it's balanced, right, between groups, and if there's differential dropout rates, which there wasn't here. But the other thing is just sheer magnitude, just sheer size. And if they were missing, you said a few hundred
Events, yeah.
Yeah. Or a few hundred people were missing. They didn't show up for their last meet.
18%.
So that's a lot. That's a high number. And so
Yeah.
even if it was balanced, I would be concerned if they didn't go into the records and find out if there was a stroke or something. I just can't imagine that, because like they need to know about death, right? So if someone doesn't show up, they need to know if they died or not, right? So
Right.
like, I don't know. I feel like just the way they conducted this, my assumption would be that, yeah, they didn't come for the last visit. Maybe they didn't get like their survey and they didn't get their last serum level, but the events were adjudicated. That would be my assumption from my read anyway.
Yeah. Yeah. Okay. So of those 5,200 people that were included, there was about 2,600 in each group. The average age was 63 years old, plus or minus 8, with just under 50% of them being older than 65 years of age. About 80% of the participants were white. The average BMI was 35, plus or minus 6. The median testosterone level was 227. And 54% of the participants entered with pre-existing cardiovascular disease, and the remaining were just at risk for cardiovascular disease. And remember that at risk being they had at least 3 risk factors of hypertension, high cholesterol, diabetes, advanced cardiovascular disease, smokers, high inflammatory markers, and a CAC score above 75%, or their age was older than 65. And now when we look at those with the cardiovascular risk factors, the majority of them were diabetes, high blood pressure, high cholesterol. Up 20% were smokers. Just over 60% had high HSCRP. And only 1% had an elevated CAC score, which I thought was really interesting. And that's probably because not a lot of people are actually ordering CAC scores, but just something that I think is really interesting. Okay. And then also something that I thought was well documented was the fact that less than 0.5% of the entire study population ever actually used testosterone replacement therapy in the past. So from like a baseline standpoint, that's probably not going to influence the results at all. And then the baseline PSA was 0.9. So you've got older white men who are at high risk or have established cardiovascular disease that are otherwise, have low testosterone and we're trying to see, okay, do these people, is anything bad going to happen to them if we give them testosterone? The average daily dose of the testosterone was 65 milligrams plus or minus 22. And then what we saw with the testosterone therapy group was that their total testosterone did go up by about 150. And then that ranged from an increase of 34 to 312 after 1 year of supplementation. So they went from a baseline of, 227 to now being anywhere between 326 and 386. So that's still kind of, I don't know what you think about that, Josh. It's kind of still like low normal.
Mm-hmm.
So it'd be interesting to if we could do a meta regression or just some sort of a regression analysis, not a meta regression, but seeing is there any sort of association between their testosterone levels and then event rates to see if there's like some sort of correlation between do higher testosterone levels while on supplementation correlate to an increased risk. That was actually something that was brought up by my attending when I spoke to her about this trial during like one of our journal clubs yesterday. So I thought that was something that was interesting. And then the placebo group actually didn't really have an increase in their testosterone. They had a median increase by 14, but that ranged from a decrease of 21 to an increase of 56 at 1 year, and that makes sense. So any sort of increases are probably just noise.
And it also indicates that there's no contamination, right? They're not like going out and getting testosterone at the clinic down the street or something like that.
Exactly. Okay. And so now let's look at the actual like numbers. Let's look at the safety outcomes. So when we looked at the composite primary outcome, 7% of the testosterone replacement therapy group had one of the composites. So they had an event, some sort of death from cardiovascular disease, a non-fatal heart attack, or a non-fatal stroke, versus 7.3% in the placebo group. So nominally, more in the placebo than in the testosterone group, but there was no statistically significant difference between the two. And it's not to say that testosterone is safer. There's just no difference between them. And that hazard ratio was 0.96, which ranged, or the confidence interval on that was 0.78 to 1.17. So not terribly wide confidence interval. And basically we're seeing no difference in testosterone replacement versus therapy for our primary outcome. When we actually subcategorize that primary outcome from an event standpoint, 3.4% for death from cardiovascular disease in the testosterone replacement therapy versus 4% in placebo. Non-fatal MI, 2.6 versus 2.4%. Non-fatal stroke, 1.4% versus 1.5%. So from our primary outcome safety data, it looks
good.
to be that for people who are at really the high risk for some sort of vascular event that are on testosterone replacement therapy, we're at least not seeing any sort of increase relative to placebo.
That's right. Yeah.
Um,
Looks good so far.
and then when we look at our secondary outcome, again, it's basically just the primary outcome and then adding in coronary revascularization to that. We see 10.4% in the testosterone replacement therapy versus 10.1% in the placebo group, with a hazard ratio of 1.02 and a confidence interval of 0.86 to 1.21. So basically, no change from the primary outcome. And when we looked at coronary revascularization specifically, we did see 5.5% in the testosterone versus 4.6% in the placebo group. However, that was still not statistically significantly different. When we looked at our tertiary outcomes, death from all cause was also not different, 5.5 versus 5.7. When we looked at hospitalization for heart failure, no difference, 2.1 versus 1.9. Peripheral vascularization, no difference, of 1.2 versus 1.3. And then when we looked at venothromboembolism events, it was 1.7 versus 1.2% in the placebo group. And then when we actually subcategorized that, there was an increase in pulmonary embolisms in the testosterone replacement therapy versus placebo of 0.9 versus 0.5%. However, that was not statistically significant. And then when it comes to DVTs, basically no difference of 0.6 versus 0.5%. And so if we were to even assume that testosterone replacement therapy, let's say, does actually increase the risk of some sort of, pulmonary embolism or some sort of, let's say pulmonary embolism, the number needed to harm there would be 250. So you would have to treat 250 people with testosterone replacement gel for 2 years in order for one person to get some sort of pulmonary embolism event. And then some other interesting findings when it comes to TIA, so mini strokes, 0.6 versus 0.7%, unstable angina, 1.7 versus 2.3%, no difference in the increased rate of prostate cancer, 0.5 versus 0.4%. However, take into account this was only in this was a 2-year trial, so we don't have enough time to really kind of see if prostate cancer would actually develop with much risk, because prostate cancers take so long to develop.
Well, and it's imperfect too, but like PSAs didn't change too much, right?
Yeah, the PSA did increase in the testosterone replacement therapy group, but really nothing that it
Not
wasn't
much.
clinically meaningful in my opinion. It went up by 0.2. versus 0.08 in the placebo. So basically 0.2 versus 0.1. So really nothing there. And then there was no increase in the rate of benign prostatic hyperplasia. So no BPH increase, 1.7 versus 1.8. Where they did find some noise and they did make some comments on this was non-fatal arrhythmias that warranted intervention was statistically significantly higher in the testosterone replacement group. It was 5.2% versus 3.3% in placebo. Atrial fibrillation, we had 3.5% versus 2.4%. And then acute kidney injury was 2.3 versus 1.5%. They did kind of highlight this pretty extensively, and they actually included it in their conclusions in the abstract. And so I think that that does warrant some talking to. Do you think that this was more statistical noise from the fact that they just didn't do testing for multiplicity, or is this actually something that needs to be looked into? My viewpoint is possibly noise. However, we kind of always want to gear towards the conservative side when it comes to safety, especially if these are things that are warranting intervention. Atrial fibrillation does significantly increase your risk for stroke, and if AFib is not well controlled, can be fatal. We have acute kidney injury. That's not anything to kind of scoff at. So, as a clinician, if this type of person walked into my office who had all these risk factors and they did have low testosterone, maybe I would mention like, hey, based on this trial, here's the safety data we have. There is some concern that there may be an increased risk for acute kidney injury, atrial fibrillation, and other sort of arrhythmias that may warrant intervention, but we kind of need more studies to really kind of investigate that. And there's probably going to be, a group of studies or follow-up studies that are actually going to have to now look into each of these three different results to confirm them. What say you, Josh?
Yeah, I agree, and I think also they were noting that there isn't really other literature to support these harms, right? And so they kind of left them as a head scratcher. It's a good point. It might just be statistical noise, but I think clinically, yeah, it'd be something that we just keep in the back of our heads and keep an eye on, I would imagine.
Yeah, yeah. So I mean, overall, I think the strength of the study was, the design, the fact that they adjudicated the endpoints. They did have a number of stop gaps in the sense of, from trial sponsorship, like who did what, and the fact they included a baseline high risk population, or both from a primary prevention and secondary prevention, cohort standpoint. If we're thinking about people who we don't want to give testosterone therapy to, it would be this group, and yet we're not seeing, based on this study, much of an increased risk with at least topical preparations for 2 years.
Yeah, I mean, I thought it was an outstanding study and pretty definitive. And it was designed to be definitive, right? To be like the definitive study. I guess the only, I am curious about those findings, those adverse events that they weren't expecting, and sort of keep an eye on that. I guess my big question, I mean, I thought it was outstanding. My big question clinically is like, what your attending was saying. Like, what about the high dose? So I don't know about your patients, but like, this is probably a great study for the vast majority of people that get testosterone replacement. But the people that I was seeing who were interested in this, like, they were all about optimization and getting numbers 800-900. Like, if it was under 800, they'd flip out and be like, no, you're high normal now, man. Like, you're like threatening the 20-year-olds. But like that I don't know that this answers that question. And it would be theoretically, I think, reasonable to do a sensitivity analysis where we just look at the top quintile levels and see if there's a signal there. Granted, we're cutting and splicing the data and we have to be careful, but I would be very interested to see that. I'd be more comfortable if it was a clean signal, lack of signal at that level. But at the very least, if you go to see your doc, you've got low testosterone, you've got symptoms, and you're high risk, the doc will be like, yeah, let's just get you into normal range, and I don't have to worry so much about your history of cardiovascular disease as I thought perhaps, but let's keep an eye on your kidneys and sort of arrhythmias and stuff like that.
Yeah, and I think too, it's like, okay, do higher levels also actually correlate to improved clinical improvement in some of your hypogonadal symptoms, or is it, hey, we just need to get you back in a normal range? Is it kind of like one of those things with vitamin D, where as long as you're not like truly deficient, as long as you're sufficient, the idea of this sort of like optimal vitamin D level doesn't really exist. Of just make sure you're not truly deficient, so you don't get like rickets. But if you're at a 35, there's not necessarily going up to 70 doesn't necessarily mean that you'll get more protection from like the flu or something. So will higher levels, will a 700 versus a 350 make you hornier, make you more jacked, make you, have better mood improvement? Or is it, hey, as long as you're just not truly deficient?
Yeah, well, you're way more active as a clinician than I am. My assumption would be with testosterone, it is linear, and you do see those incremental improvements over time. It's not like a threshold effect. Is that not your experience or your knowledge on that?
I typically just try, when I'm managing patients, I'm just making sure that we're not being too aggressive with it. I kind of just stay within that range of the AUA guidelines. And, once we've kind of achieved like a normal range and on a steady dose and people are tolerating things, I just kind of keep them there.
Yeah, so I think your population is probably more normal, but I think, for those listeners where they're in the functional medicine space or things like that, where the patients are very interested in getting those higher levels, I wonder. But looking at these graphs here, the ranges of testosterone, they don't go that high. I mean, even at the upper bound, we're talking about like 550s, things like that.
Hmm.
Median levels or mean levels there of 350. So yeah, I mean, I think your attending's question is a good one. Like, what about those patients who are getting up there 6, 7, 8, 900? What does that mean? Can we be as, have the same conclusions that we have from this? But at the very least, I'd say the way you're describing using it in clinic, I would imagine you get a lot of comfort from this study for those higher risk patients.
Yeah. But I also get a little bit of discomfort because if we think about our limitation, like, okay, the population that wasn't included, what if we have younger guys coming in with hypogonadal symptoms, who don't have these risk factors? Does the risk of supplementation change for them, or do we probably think that they're in the clear?
Well, my assumption would be with the lower baseline cardiovascular disease be even less of a signal, if anything, right?
Mm-hmm. Mm-hmm. Yeah, and I mean, it was also limited to topical formulation. So does that change your practicing patterns of like switching from injectable testosterone to now just topical preparation?
Yeah, I wanted to ask you about that too, because they're doing blood levels, but I guess you could argue that the spikes would be different, and that maybe the peaks and the troughs would be different based on the whether it's a gel versus an injection, etc. And then, do we have any evidence that it's the peaks that are associated with the risk, or not so much?
Well, they measured all testosterone levels, repeat levels, 24 hours after their topical application, and
Hmm.
they're taking them daily.
Right, but like if you got an injection instead,
I
would
see what you're saying.
that curve look different than doing daily gels?
Yeah, I don't know.
Yeah, and I don't know if that's associated with risk, but to your point, like this study is about gel,
Yeah,
but and while they checked blood levels, I guess you could make an argument for peak and trough differences that may have an impact, but it's just one of those unknown things.
yeah. So it looks like the takeaway of the study is, using at least 2 years of testosterone supplementation gel in a very high risk cardiovascular patient base, it does seem to be safe compared to placebo. However, there is some noise around atrial fibrillation, acute kidney injury, and other arrhythmias. But from a purely like, will you stroke out and have a heart attack,
Hmm.
seems to be safe compared to placebo, at least in the short term, and based on some data that may have been missing.
Yeah, I think that's 100% correct. And thanks for bringing this up because I think it is super clinically relevant and literally a week old as of
Yeah,
today. So that's pretty cool. Very
this
timely.
is cutting edge stuff, people.
What's that?
This is cutting edge stuff for our listeners.
Cutting edge. That's right. In-depth analysis. We're probably one of the first. Did you listen to the looks like they had like a podcast or something, a video about it? Did
They
you listen?
usually have on the website like
Mm-hmm.
video releases with their most recent
Quick
publications.
takes type of thing.
Yeah, and then they also had a commentary piece on this that I thought was interesting too, and they kind of talked about some of the stuff that we already mentioned.
Nice. Well, because we nailed it and we're really good at this sort of
Oh
thing.
yeah, duh.
And so, New England Journal of Medicine, if you're listening, and we know you are, just call on us if you have any questions. If you want a podcast, we can outsource that to you as well. No problem. You could white label it if you want. Just saying, we're available. All right.
How can people find us, Josh? If they want more,
people can find us everywhere. We're all over social. We're on www.drjournalclub.com, drjournalclub.com, and that's really the flagship of this organization, where we go into in-depth training on how to evaluate research articles. There's little bite-sized videos on risk ratios and inferiority trials and meta-analyses and all these little concepts that you could just quickly go in and get answers to. But then, of course, we also go through and summarize recent research, just like this one. And so, Adam, are you going to be coming out with one? Are you going to be releasing it on Dr. Journal Club?
I will release this on Dr. Journal Club because it comes with graphics and whatnot. And then also there will be 2 studies that I posted on Instagram that we will not talk about on the podcast, however, are also very clinically relevant. One is on the use of ketamine compared to electroconvulsive therapy for treatment-resistant major depression. There's a big
hot topic right now.
Interest in psychedelics and ketamine for in the field of psychology. So that was a really interesting study that we're going to dive very deeply into. And then also the use of treatments for osteoporosis when it comes to postmenopausal women, which intervention seems to be the best compared when looking at all of the available evidence.
Yeah.
And so that's also very clinically relevant to a lot of us in primary care. And so that will only be available to members on Dr. Journal Club as well.
Awesome. Thanks, Adam. And thanks for keeping it so clinically relevant. You can thank Adam for us talking about things that will impact your clinical care, as opposed to me, who wanted to wax poetic about the philosophy of EBM and the cross-discipline perspectives from chiropractic to naturopathic medicine. Our conversation today was probably way more useful to you clinically. All right, let's take it out from there. See you, Adam. Thank you so much.
Yeah, catch us on at Dr. Journal Club on Twitter and Instagram. All right, see you, everyone.
If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media at Dr. Journal Club, Dr. Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.